Hey everyone, it's Loretta. I wanted to talk to you a little bit about documentation and billing. Documentation is one of those necessary evils in all medical treatment, but in physical therapy in particular. It's something that you need to do. So nobody ever says, "Well, I love doing documentation, but I really don't like doing the therapy." It's the other way around. I love doing physical therapy, but the documentation is something I have to do, not something I like to do. So the learning objectives for this section are to be able to accurately document physical therapy treatments in a SOAP note format. That is the format we'll be using throughout the program. You will see other formats in different places in the clinic, but they are all, for the most part, based on a SOAP note. And the same information goes in. And we want to be able to do that in an accurate and timely manner. We want to be able to report the appropriate CPT code for each PT intervention that you learn and to accurately record the billing units for each treatment session. So this is something, and I'll talk a little bit about this at the end of this section. It's an art. It's not a science. It's something that you learn and you figure out and you do it different ways. But you want to be accurate and you want to keep a good record. So one of the main, there are lots of reasons for documentation. One of them is to document in the medical record. One of them is to document a legal record. So if it ever comes about that somebody sues you or your clinic, you don't want that to happen. But a lot of times your SOAP note is the only thing you have to go on it. So I've fortunately never been involved in anything like that. But some of the people that I've worked with in the clinic have, and most of the time you're not going to testify in court or anything, but you're going into a lawyer's office to do a deposition. And what they give you is your SOAP note that you wrote on that day or the days in question. And boy, you better hope you wrote a good note so you remember what it is, because it's probably years later from when it happened. So you might not remember. And what you wrote in the note is important to what you're going to remember about that patient. So you can almost think of the note as a note to your future self, as in one of its manifestations. Another person reading your note is going to be like an insurance adjuster who is deciding if your clinic is going to get paid for this note, for this treatment that you got. So part of it is a financial record. They're saying, did you do enough to justify us paying you for this treatment? And the other person that might be reading the note is the patient. So the patients these days have access to your electronic documentation. They can log into the chart, into the portal for your system, and they can read what you wrote in the notes. And so you want it to be accurate and understandable for them. Another person reading the note might be the referring physician. So that person wants to know how the patient is doing. Are they progressing as expected? Are there any issues with their PT? So we're trying to communicate with a lot of people with one little note, and we are trying to keep an accurate medical record, an accurate legal record, an accurate financial record. So all that in a tiny little note. Let's see how to do it. So helpful tips for writing SOAP notes in the classroom or in the lab. We're going to be documenting in the clinic treatments for all the patients we treat, whether we're in the lab or in the clinic. We're going to be documenting everything. So when we're in school for each case study or lab practical, you're going to be provided information, something similar to what you would see in a PT initial evaluation. And using this information, you're going to perform the treatment for this treatment session, and you're going to document that treatment. So in school, we don't have real patients with real injuries or illnesses all the time. And there might be a little bit of creative writing. I really struggled with this when I was in school because, I was used to scientific writing, and you write down what you measured and that's it. So the creative writing part was a little hard for me. So we don't have real patients, so you might have to make a few things up, but try to make up things that make sense when you're in school. Of course, when you're in the clinic, you're not making anything up. You're going to do the treatment, you're going to write what you did, why you did it, and how much you charge for it. So keep that in mind. So the subjective section is basically what the patient tells you. And what are you going to write down every little thing that they tell you? No, you're not. Because some patients, you need to drag information out of them. Some people will tell you their life story. You're not going to write that all in the subjective section. You're going to write reproducible functional applications related to the patient's main limitation. So this is a list of some of the possible things that the patient may have stated to you that are relevant to document. So you're going to do, it's the patient's report, their functional limitations, what relieves their issue, what aggravates their issue, what improvements they've made since the last time they were in. So you're going to talk about chief symptoms, current symptoms, what their goals are, their functional status or activity levels, their social history, employment status, living environment. So obviously you're not going to document all that, but those are potential things that you could document. And response to the last PT treatment, that's important. Sometimes people will come in, the PT did their initial evaluation and they're seeing you on the second visit and they say, wow, I was really sore after the initial evaluation or after my last treatment. That's a good thing to put in the subjective section. And their current pain levels. So pain levels, we put in the subjective section. Pain isn't objective data. We can't measure it. There's no painometer. But it's subjective. It's what the patient is telling us. Sometimes we have to prompt people to get the information that we want in the subjective section. So you might have to ask some open-ended questions, like what things do you do that aggravate your problem? Is it worse in the morning or in the evening? If you sit down and rest, is it better? You know, kind of sometimes you have to drag information out of people. What aggravates it? What makes it better? The way you write the subjective section, in the old days, we used to say patient complains of. Well, we kind of don't want to do that anymore. We don't want to say that the patient is complaining. They're reporting. So you could say patient reports or patient states. However, you don't have to write that in every sentence. So I have seen SOAP notes that students have written that say, patient reports this, patient states that, patient says that. You only have to say patient reports one time, and then you can write all the rest of the stuff they said. Sometimes you're not going to get an accurate or complete report from the patient, but their spouse or caregiver or family member can give you more important information. So I'm working with the patient and her daughter brought her in, and her daughter said, she's doing a lot better with her transfers and she doesn't need my help most of the time. So I'll write that in. I'll say patient's daughter reports that she's doing better with her transfers, you know, something like that. So some things that the patient's family members or caregivers say are definitely relevant and fair game for the subjective section. So the next letter in the SOAP note is objective. So objective includes your measurements or observations that you take. And there's a huge range of information you could put in here, but you want it to be measurable, repeatable, and meaningful to the treatment. Observations count as measurable and repeatable, and I'll talk about some examples of that. The other part of the objective section is the treatment that you did, and we'll talk about that in a minute. But things that you can measure, and a lot of times when you're doing a treatment, you want to measure pre and post. So like edema or girth measurements, say someone's got a lot of swelling in their knee or their ankle or whatever body part you're working on. You measure them before the treatment, you do the treatment, and you measure them after the treatment, and you document those measurements all in the objective section. And then you can comment on them in your assessment and say, hey, their edema was reduced during the treatment. They had reduced edema. That's nice. If you do good objective, then the assessment practically writes itself. So you can do sensation testing. You can do strength testing, balance, skin integrity, or inspection. So a lot of times after when you're working with a post-surgical patient, you'll say incision is well healed and steri-strips are in place, or incision is healing with no exudate, whatever, whatever you see, you're going to report that. You can even take a photograph of the incision or of the wound or whatever it is and put that in your objective section. A picture is worth 1,000 words. I'm all for that. Vital signs are objective data. Test results, like you did the Berg balance test, that goes in the objective section. Range of motion, posture, level of assist for transfers, level of assist for all functional activities, walking, stairs, etc. Edema and girth measurements, like I was talking about earlier. Neurological testing, so testing proprioception or cognition. There are some standardized cognition tests like the mini mental exam, and you would put that data in your objective section. Outcome measure results, so any functional outcome measures that you use. And throughout the program, we'll talk about lots of different functional outcome measures, because what we are looking at is the treatment we're doing making a difference for this person in a measurable or observable way? Okay, so that's the point of the objective section. What's measurable, what's observable, what's repeatable in the next section to show that they're making progress in the next session. So in the treatment section of the objective notes, what we want is clear descriptions of the interventions you performed during the treatment. And that includes the parameters of what you did and the reasons for the intervention. So you don't just want to say that you did ultrasound times 10 minutes on this body part. You want to say you did ultrasound times 10 minutes with these parameters on this body part for these reasons. And here was the patient's reaction to it. Well, you put that in the assessment. So clear descriptions, what you did, how you did it, and why you did it. For each treatment session, you really need to document not just what you did, but why you did it. And you're not documenting what the patient did, you're documenting what you did. What skilled physical therapy treatment did you provide for that patient? Okay, so you're not going to say patient performed this, patient performed that. If you're doing exercise or something, you might say reviewed and corrected form for transverse abdominis isometrics and progressed exercises to include supine marching to improve core stability. That's why you did it. So what part of the plan of care are you addressing with the interventions you performed? So if the plan of care was to improve core stabilization to decrease back pain, that's why you did the transverse abdominis. That's why you reviewed and progressed the transverse abdominis isometrics. That's why you did it. You're addressing that part of the plan of care. Okay. If you did patient instruction on anything, patient instruction on their home exercise program, patient instruction on how to use ice or heat at home, we're going to say that part of the plan of care might be that the patient is independent with self-care and pain management activities at home. If you said instructed patient in the use of ice or heat at home, you're addressing that part of the plan of care to make sure that they are independent with self-care and managing their pain at home. So in the objective section, it's not just a list of what we did, it's a list of what we did, how we did it, and why we did it. What we did, not what the patient did. In the assessment section, we are going to summarize the response to treatment, including improvements made during the session, how the patient benefited from the session. It might include progress towards goals or limitations preventing the patient from meeting the goals. So lots of things could go in the assessment. If you wrote good objective and you measured good objective, then you can comment on that in your assessment. So if you said pre-treatment, their shoulder flexion was this many degrees, and post-treatment, it was this many degrees. In the assessment section, you could say, patient improved shoulder flexion by 10 degrees during the session. Yay, that's a good assessment. You could say what problems they still have to address. Or you could talk about progress towards their goals or long-term or short-term goals met. So you could say patient met the goal of being able to walk 100 feet with their four-wheeled walker with distant supervision, something like that. You could say how they reacted to today's treatment. So you could say you could say that the patient reports improved ease of movement after today's treatment. So that there's a little subjective information in there, but it's telling their reaction. Or you could say patient was very fatigued by the end of today's treatment, requiring a seated rest before they could leave the clinic. Maybe we worked them too hard and we need to take it down a notch next time. Who knows? What are they still lacking to achieve their goals? What are they still limited by? How is PT intervention going to continue to help or benefit the patient? So you could say patient would benefit from additional skilled treatment to work on safety in transfers. That's how they're going to continue to benefit if they keep doing PT. Okay, so the assessment section should refer to the objective section. You should show improvements with your measurements, or show if they didn't make any improvements, you could say that too. So sometimes I'll say something like, patient's shoulder range of motion improved by this much, as backed up by my objective data, but they still continue to have pain at the end range of motion. Something like that. So here's how they improve, but they're still having problems that we need to address. In the plan section, we want helpful, meaningful information for the next visit, including at least one specific progression of the treatment. So you might not always have that in the clinic, the specific progression of the treatment. It's a good idea, but in class, we're going to require that you have that. That is something that we really want. So remember, the plan is not what the patient is going to do. The plan is what you are going to do in the next section. So I like to think of the plan section as a note to your future self. I'm going to say, wow, I really want to do this, this, and this in the next session. Am I going to remember that between now and the next session? Maybe not. So I'm going to write it in my plan, and then I will remember it because it's right there. What if somebody else is seeing that patient the next time? Well, write down the plan for the next therapist. It's a note to the next therapist. So specific plans for progressing exercise. So you have a particular exercise you're doing, specific ways that you want to progress it. The location of the treatment, particularly if it's changing. So you could say, continue to work on left shoulder range of motion, but add isometric strengthening exercises in the next treatment, something like that. Plans for further assessment. So you say, retest the neck disability index at the next session. So you're going to do a functional outcome tool, and you're going to remember to do that at the next section. Activities to try in the next PT treatment. So I'm working with the patient and they say, I really want to start trying stairs now. And so I write, and we're at the end of the session, so I write in my plan, try stairs next treatment. so I remember that we wanted to do that. A treatment progression, particularly if you're following a specific protocol. So some post-surgical protocols will say they'll have like weight-bearing limitations to a certain number of weeks after surgery, or things that you can add in a certain number of weeks after surgery. So you could say progress to phase 2 of ACL protocol by adding this and that, by adding whatever's in phase 2. A lot of surgeons have their own particular protocols, a lot of orthopedic surgeons that they will provide to you. A lot of clinics have their specific protocols that they use for particular surgeries. Discharge planning. So you could say 2 more visits before discharge, and then say specifically what you're going to work on. Or you could say discharge next visit per PT plan of care, assess Berg balance scale before discharge. That's a good plan because I know what I'm going to do the next session. I'm going to do the Berg. So you want to have a specific plan for what you are going to do, not what the patient is going to do. Anything about what the patient is going to do, is going to go in the treatment section. Okay. So if you're going to add things to their home exercise program or something, put that in the treatment section. So that's the plan, is always the plan for you, the plan for the next therapy session, what you are going to do. Legibility. Most documentation these days is electronic. So you don't have to worry about your handwriting being legible. You are going to write some notes by hand in class. Largely in the clinic, you're either going to be dictating or you're going to be typing. So if you want to write a note, an electronic note, and you want to use voice to text to practice dictating, I think that's a great idea. I think it's great practice because a lot of clinics, you are dictating your notes. However, if you are using voice to text or any kind of dictation software to dictate your notes, make sure you proofread that, because voice to text likes to get crazy with the words and write something that you didn't say. So that's something that you should do. So in my clinic, you have the choice of dictating or typing, and most people do a combination of both. Some people only dictate, and sometimes their notes are crazy because they don't proofread. You want to make sure you're using correct medical terminology and abbreviations. When you're doing electronic or dictated documentation, it is not necessary to abbreviate everything as much as when you're doing handwritten. And in fact, I would discourage the use of abbreviations, except the really common ones, like ROM for range of motion. And a lot of times when you're typing, it's a lot easier to type out the word than to type an abbreviation. You want to do things in the present tense, because the idea is now they want real-time documentation. You're not waiting till the end of the day to document. You are documenting in the session or directly after you finished the session. No spelling errors. Gotta spell things right. It's a legal document. The note needs to be signed and dated. Your name, SPTA is your title, student PTA, and the date. So the present tense is, we're telling how the patient is doing right now in the present. Hopefully that makes sense. So when we get to the charging part, the billing section of the note includes appropriate CPT codes and billing for the appropriate number of units. So we're going to talk about something called the 8-minute rule, which can be confusing as heck, but I want you to think of the number of units in 15-minute blocks. So if you have an hour-long treatment, it's 4 15-minute blocks. You might be a little more on one thing and a little less on another, but it adds up to pretty much 15-minute blocks. If you have a 45-minute treatment, that's 3 15-minute blocks. If you have a 30-minute treatment, that's 2 15-minute blocks. You're really going to have a 15-minute treatment. I don't know, I think maybe I've done applied an iontophoresis patch for someone, just a 15-minute treatment, but that's rare. You're not usually going to have that. So CPT codes are published by the American Medical Association. So there's CPT codes for everybody, not just for physical therapy, but there's a specific range of codes that are for physical therapy. So in the CPT code set, they use terms like physician, qualified healthcare professional, or individual. So that doesn't mean that doctors can use the physical therapy codes or physical therapists can use the doctor codes. Well, you can use them, but they won't reimburse you for them. So same thing with occupational therapy. Some of the codes cross over with us and some of them don't. So but whenever they say qualified healthcare professional, physician, or provider, that is you. You're the provider. You're providing the medical service. You are the qualified healthcare professional. Okay, just so you know on the terminology. So for time-based codes, there are some codes that are untimed, and we'll get into that as we learn these more. But just know for time-based codes, it's basically a 15-minute block, but in order to sort of claim that 15 minutes, you have to provide direct treatment for at least 8 minutes to receive reimbursement. So if you did a 7-minute treatment, you did it for free because it's not reimbursable. So that's for all insurances, including Medicare. When the insurance payers calculate the number of billable units on a particular date, they add up the total minutes of skilled one-on-one therapy and they divide by 15. So basically you're getting, so if you did 45 minutes, divide by 15, and if 8 or more minutes are left over, you can bill for another unit. So if you do 38 minutes of treatment and divide by 15, you get 2 15-minute blocks, and that adds up to 30 minutes, and then you get 8 minutes. So that's 3 units, 2 15-minute blocks and 1 8-minute block. If you do 37 minutes of treatment, you can bill for 30, but that 7 doesn't count. So commonly used CPT codes, and in your procedures classes, we'll introduce the ones we're using for those classes. So we're not going to just all at once throw these all at you and say, hey, charge the right code. we're gonna dribble them in little by little with the things that we're learning in that particular class. So hopefully this is good. But basically, therapeutic exercise, neuromuscular reeducation, all of the modalities, ultrasound, electrical stim, manual therapy, gait training, wheelchair management, self-care, orthotic and prosthetic management. So lots of different codes. They're all in the 9-7 range, 9-7. They'll start with 9-7. And we're going to charge the code that's appropriate for what we did with that person. So that having been said, therapy billing is not a science, but an art, sort of. So a lot of physical therapy practices underbill or use the wrong codes, and therefore they get underpaid. And how that affects us is if our employer is getting underpaid for services, they're not going to be able to pay us as much, or they might not even be able to afford to pay us at all, and we might have to go look for another job someplace else. So you don't want to spend an hour with a patient and only bill for 2 or 3 units of care. That is a lesson that I learned early on in my career. I worked with in a skilled nursing facility with a rehab manager who was really good at coaching new therapists. And she told me, I had a performance review, and she told me that she thought I was underbilling. And so we talked about how I could do that. And I ended up wearing a stopwatch around my neck, and I would time every single thing I did with people and make sure that I got everything out of the session that I could get. So you want to make sure you're billing for your time. And that having been said, you want to make sure that you are using the time in the session wisely. You are not wasting the patient's time, and you're not wasting your time. So your sessions should be packed with activities. If the patient has to rest physically, you can do education while they're resting. You can teach them breathing techniques. You can teach them about things that they should do at home. So don't waste the patient's time, and don't waste your time. So there can be variations in what code you're going to use for the exact same thing. So this is an example. So I'm going to show a patient, I'm going to teach a patient how to perform an oblique abdominal sit-up. So you go, well, that's easy, therapeutic exercise, right? It depends. So the answer to a lot of things is it depends. If you're teaching a patient the exercise to increase strength and flexibility, then yeah, it's therapeutic exercise. That's why you did it. And so you would say, instruct a patient how to perform oblique abdominal sit-up to increase strength and flexibility in the trunk. You're going to build therapeutic exercise. However, if you're showing the patient this exercise for the purpose of facilitating dissociative movements between the lumbar and thoracic segments, thereby improving proprioception or decreasing axial rigidity, which is common in some neurological disorders, you can bill the CPT code 97112, neuromuscular reeducation, because you're trying to improve proprioception, you're trying to counteract the axial rigidity that happens in some of those basal ganglia disorders, and you're trying to re-educate the neuromuscular system. So that's 97112. However, if you're showing the patient the exercise for the purpose of improving functional performance and getting out of bed, because you got to do that, oblique movement and get up out of bed, you can bill the CPT code 97530, therapeutic activities, because the purpose is improving their functional component for ADLs, for getting out of bed. Really important. So lots of ways you can bill for the same thing. And depending on your intent, there is a proper CPT code to use. So, but you have to make sure to justify your treatment intentions and document them properly in order to avoid problems later. So the thing you would change in your documentation, depending on what you would build, is the reason for doing it. So you would say, instructed patient in this exercise to increase strength and flexibility in the trunk. That's therapeutic exercise. If you did that same instruction to facilitate dissociative movement between lumbar and thoracic segments to improve proprioception, 97112. Instructing patient how to perform oblique abdominal sit-up to improve functional performance of getting out of bed, that's 97530. So the reason that you did it, that's going to determine your variation in coding. So hopefully that makes sense. So here's the 8-minute rule. And if you think of treatment in 15-minute blocks, that is a really good way to think about it. And don't worry too much about the 8-minute rule now. It will start to make sense later on. It might not make any sense right now. But so basically 1 unit is 15 minutes, 2 units is 30 minutes, 3 minutes is 45 minutes, 4 units is 60 minutes, and 5 units is 75 minutes. But there's a little bit of leeway. So 8 to 22, 23 to, so if you do something for 22 minutes, you can still only charge for 15, 1 unit. If you do it for 23 though, you can charge for 2 units. So that's where, think of the cutoff points is like, I have to get at least 38 minutes of treatment in to charge 3 units. So if you think of your cutoff points, what those are. So, but if you think of things in 15-minute blocks, I think that is the easiest way to think of it. But in order to charge a single unit, you have to do direct treatment for at least 8 minutes. And if you can go as long as 22 and you're still only charging 1 unit. So you think of it as 15 minutes plus or minus a few minutes. So, and that's what insurance companies do. They go, okay, you had skilled one-on-one therapy for 38 minutes. I'm going to divide by 15. I get 2 units. And then the 8 minutes, which adds up to 1 unit, so you can charge 3 units. If you build 37 minutes, you can only charge 2 units. So it's not the best use of your time. I'm only charging 2 units for 37 minutes. So don't get too hung up on the 8-minute rule. Think of it in 15-minute blocks. It'll be a lot easier, I promise. And the subtleties will come to you as you practice. So the current CPT codes are always published by the American Medical Association, and any changes, they have kind of updates too. I think there's a new update since this one, since the 2018 one. But if you really want to read the details, if you're having trouble sleeping at night and you want to get put to sleep, you can get that information from the American Medical Association.